Let us continue with the lecture. In this case, hemisection of the spinal cord is affected, that is, one whole section of the spinal cord is affected, that is, the lesion is present on one side. The clinical features as a result of this lesion collectively known as Brown-Sequard syndrome. In this condition, if the semisection of spinal cord is affected, then the dorsal column sensations are lost, and also the ascending tract and descending tract through this segment of the spinal cord are also lost. So first we will see the dorsal column sensation. The sensory nerve fibers that are entering the spinal cord, they go upwards on the same side, they do not cross. So the lesion is on one side, so the problem is on the same side. So what are the dorsal column sensations? Tactile discrimination, vibration, position and fine touch. So there will be ipsilateral loss of dorsal column sensations for this patient. Next we see the ascending tracts of this spinal cord. In this section of the spinal cord, you have the dorsal spinal cerebellar tract. So what is the function of the cerebellum, headquarters of coordination of movements? So there will be disturbances in the coordination of movements known as dystaxia. So let us see the pathway of dorsal spinal cerebellar tract. This is the slide about dorsal column tract pathways. They enter the spinal cord and move upwards on the same side. They do not cross. This is the right side, this is the left side. So let us see the dorso spinal cerebellar pathway. So here the tract, it enters the spinal cord, it goes upwards on the same side. So you will have ipsilateral lower limb dystaxia because it is concerned with the coordination of movements. Then ventral or anterior spinocerebellar tract. Let us see the tract pathway. Ventral or anterior spinocerebellar tract, it enters the spinal cord and it crosses and it moves upwards to the cerebellum. So here is the anterior side, here is the lateral side. So it crosses and go to the anterior side and then move upwards. So there will be contralateral loss because the lesion is on the hemisection. If the lesion is here, then the problem will be on the other side since the information is going through the other side. Lateral spinothalamic tract also affected. So what is the function of spinothalamic tract? Pain and temperature. So let us see the pathway of lateral spinothalamic tract. So lateral spinothalamic tract, it enters the spinal cord, it crosses and on the lateral side and then it moves upwards. So the lesion is on the hemisection of the spinal cord. If the lesion is on the right side, the information is carried through the left side. So the clinical feature, it will be seen on the left side. So there will be contralateral loss of pain and temperature. Please note that in lateral spinothalamic tract, the clinical features, it will be seen one segment below the lesion, that is contra loss of pain and temperature, it will be seen from this spinal cord segment if the lesion is here. Then anterior spinothalamic tract. Let us see the anterior spinothalamic tract. It is concerned with the function crude touch and pressure. So anterior spinothalamic tract, it enters the spinal cord, it crosses, it goes to the anterior side and then move upwards. So the same goes for anterior spinothalamic tract. If there is a lesion on the hemisection on one side, that is on the right side, the clinical feature, that is the contralateral loss, it will be seen on the other side, on the left side. Please note that the contralateral loss clinical feature, it will be seen 3 into 4 segments below the lesion. That is the clinical feature, it will be seen from this spinal cord segment if there is a lesion present here. Then the descending tract, that is the corticospinal tract, is also affected. I have not discussed this descending tract lecture yet. We will have the topic later on. So corticospinal tract is a upper motor neuron, that is, it is from the cerebral cortex of the brain to the spinal cord. So here, this corticospinal tract, we will see the pathway. This is the corticospinal tract, lateral corticospinal pathway, anterior corticospinal pathway. From the cerebral cortex of the brain to the spinal cord. So the lateral corticospinal pathway, it crosses in the medulla and then goes straight on the lateral side. Then down the spinal cord, it does not crosses. For the anterior corticospinal pathway, it goes on the same side. So please note that if there is a lesion on this spinal cord segment, the lower motor neurons are affected, but the next spinal cord segments, the lower motor neurons are working good, they are not affected because the lesion is only on this spinal cord segment. The corticospinal pathway, that is the upper motor neuron, that is coming from the brain to the spinal cord in this way, in a straight way. The information is carried by the corticospinal pathway is stopped here because the lesion is here, so it is stopped here. The information will not pass through these spinal cords. So these spinal cords will have upper motor neuron type of problems. So below the level of lesion, the spinal cord segments will have upper motor neuron type of problems, that is spasticity, hypertonia, hyperreflexia and Babinski sign, which is upgoing. Then you also have lower motor neurons coming out from your spinal cord to your body, that is also affected. So in this spinal cord, the patient will have lower motor neuron type of problems, that is flaccidity, severe loss of muscle mass, hypotonia, hyporeflexia, fibrillation, fasciculation. Here the lesion is on one side, so the problems, it will be on one side. And this Brown sequard syndrome, I forgot to mention, it commonly occurs around cervical vertebrae 5 and 6 level. 5 and 6 level, you know, C, T, L, S, C7, T12, L5, S5, C4. So the Brown sequard syndrome, it commonly occurs around C5 and C6 vertebral level. So again, I have stressed this, below this C5 and C6 level, if the lesion is around C5 and C6 level, below you have C7 vertebrae, then T1, T2, then it goes on. So from the C6, from the C7, you will have upper motor neuron type of problems. And also you have dorsal nerve fibers, that is sensory nerve fibers entering the spinal cord is also affected. The information from the body carried to the brain is also affected. So here the whole hemisection of the spinal cord is affected. So there will be complete anesthesia on one side. So there will be loss of pain, temperature, vibration, position and 2-point discrimination. Please note that this Brown-Séquard syndrome, this lesion hemisection of the spinal cord is common around C5 and C6 vertebral level. So consider this as C7 T1. So below the level of lesion you will have ipsilateral spasticity, ipsilateral loss of dorsal column sensation and contralateral loss of anterolateral sensation. Why below the level of lesion you have ipsilateral spasticity? Because this sensory nerve fibers carrying the information from the body, it is passed here to the brain. Here is the lesion, but what happens is the sensory nerve fibers coming from the body to the brain carried here, it cannot go beyond this lesion, it is stopped here. So these segments will have ipsilateral spasticity because of not able to pass the information from the body to the brain. These informations are stopped here. So there will be ipsilateral loss of spasticity, ipsilateral loss of dorsal column sensations. Why contralateral loss of anterolateral sensations? As you know, the sensory nerve fibers, you know the pathway. For the anterior side they will cross and they go upwards. For the posterior side, for the lateral side they will cross and they will go upwards. So there will be contralateral loss of anterolateral sensation. So here please note that at the level of lesion, the information is passed, but below the segments of the lesion the information is stopped. The same goes for corticospinal tract. The information is passed until this vertebral segment, but the information cannot go to the other segments from the brain. So this is the basic concept, so please do not get confused. I have already told you that this Brown-Séquard syndrome, that is hemisection of the spinal cord, it happens around C5 C6 level. What if it occurs around T1 T2 vertebral level? Around T1 and T2 vertebral level you have nucleus of buds on the lateral side of the spinal cord. These nucleus of buds are concerned with the sympathetic supply of eyes. So there is a lesion, so the sympathetic supply of eyes are also affected only on one side because the other side is normal, there is no lesion on the other side. So the normal function of sympathetic supply of eyes is to keep the pupils dilated, that is pupillodilatations. If there is a defect to the sympathetic supply of eyes, then there will be pupilloconstrictions, that is miosis. Dilations means mydriasis. Constriction means miosis. This is known as Harner syndrome. Harner syndrome also involves anhidrosis on face, partial ptosis, apparent enophthalmos. What is anhidrosis? Loss of sweating on one half of the face. Since the lesion is only on one side, there will be ipsilateral Harner syndrome. So there will be loss of sweating on one side of the face. Ptosis means drooping of upper eyelid. Here the problem is with the eyelid, upper eyelid. But here in apparent enophthalmos, the eyeball, you have eye sockets and the eyeball floats in your eye socket. But in enophthalmos, your eye, it will sink in the eye socket. So you can see the level of the eyeball. So this is all about Brown-Séquard syndrome. Then we will move on to the next case where there is a complete transection of spinal cord. That is, the lesion is on the whole spinal cord section. So the reason why I have told you to remember the location of the different segments of the spinal cord is because if the lesion is at C1, C2, C3 level, that is C1, C2, C3 are near the brain stem. So if there is a lesion in C1, C2, C3, this is known as excitus letalis, that is, there will be definite death due to various problems because the lesion is located above the medulla oblongata. In case if the patient survive, there will be the patient will have upper motor neuron loss, spastic paralysis, hyperreflexia, hypertonia, Babinski sign which is subgoing, complete anesthesia below lesion because the motor nerve fibers are affected, so the patient will have lower motor neuron type of problems, and the patient also has upper motor neuron loss because the corticospinal pathway is also affected, and sensory nerve fibers entering the spinal cord are also affected, that is dorsal column sensations are also lost. Then because of this the patient will have urinary and fecal incontinence with reflex emptying. So what is this reflex emptying? Here in this spinal cord, whether it is C1 or C2 or C3, the lower motor neuron is affected because of the lesion, but the corticospinal pathway is going good in this spinal cord. Only the spinal segments from here, they will have upper motor neuron type of problems because the information from the corticospinal tract, it cannot come to this spinal segment. So here the information from the brain is passed until this segment, so there will be normal reflexes, but because of the lower motor neuron type of problems, it cannot be executed. So the patient will have the reflex, and it cannot be executed. That is known as urinary and fecal incontinence with reflex emptying. Urinary and fecal incontinence means normally in an anal opening there is a sphincter muscle. The function of the sphincter muscle is to keep the anal opening closed. If there is a dysfunction to the sphincter muscle, the anal opening, it will remain open, and that is a problem. The same goes for urinary bladder, that is the bladder function is to store urine. There is also sphincter muscle, it will keep the bladder closed. But if there is a dysfunction, the bladder can no longer hold the urine. The patient may pass out urine at any time, and the patient will also present with anhidrosis, loss of sweating, loss of vasomotor tone below the lesion, that is from the next spinal cord segment. Please note that if the transaction is above C5, that is in C3, C4, C5, the respirations are also affected. So that's why the immediate death because of the respiratory arrest, because phrenic nerve supplying the diaphragm is from these vertebrae C3, C4, C5. I have discussed this in the respiratory lecture. In the next case, the lesion is at cervical vertebrae 4 and 5 level. If the lesion is at C4 and C5 level, then it will affect both the upper limbs and lower limbs. This is known as quadriplegia. If only one side of the body is affected, that is one upper limb and one lower limb is affected, it is known as hemiplegia. 4 limbs are affected, it is known as quadriplegia. So what is paraplegia? Only the lower limbs are affected. What is diplegia? Either upper limb or lower limbs are affected. The next case, the lesion is at thoracic vertebrae 1 and 2 level. If the lesion is at T1 and T2 level, it will affect the lower limbs. Then the patient will have a spastic paraplegia. Then we move on to the next case. In the next case, there is interruption to the blood supply to the spinal cord. So the spinal cord is supplied by your anterior spinal artery, one anterior spinal artery and two posterior spinal artery. So this anterior spinal artery, it supplies 2/3 of your spinal cord, that is until here it supplies. So if there is an interruption in the form of thrombosis, that is a blood clot or any other diseases, what happens is the blood supply to this 2/3 of the spinal cord is stopped. So basically there is a lesion at 2/3 of the spinal cord in the form of infarction or due to other causes. So at the level of lesion, that is at this spinal cord segment, there will be lower motor neuron type of problems. Below the lesion, that is the next segments below the spinal cord, there will be upper motor neuron type of problems. And then the ascending tracts and descending tracts are also get affected, and you will have the respective clinical features. In the next case, in a spinal cord, the tip of the spinal cord, lower tip of the spinal cord is known as Conus Medullaris. Above Conus Medullaris you have epiconus. On the sides there are bundles of nerve fibers, both sensory and motor nerve fibers coming out, and this bundle is known as Corda Aquino. And you have filum terminale that ends with the dura mater. So if there is a lesion at these locations, then the patient will have the respective clinical features. So I will discuss this one by one. If there is a lesion at the epiconus of the spinal cord, then there will be epiconus syndrome. This epiconus syndrome, it occurs around lumbar and sacral vertebrae L4 and S2. If there is a lesion at the conus medullaris, it is known as Conus Medullaris syndrome. It occurs around sacral and coccygeal vertebra S3 and C0. And if there is a lesion at the Corda Aquina, then the patient will have Corda Aquina syndrome. And filum terminale syndrome is because the filum terminale, it becomes thickened, fibrotic and shrunken. It is seen at the level of thoracic vertebrae T3. So let's see the individual syndromes. And this is a picture which shows your Corda Aquina, that is a bundle of nerve fiber tracts, and here you have Conus medullaris, epiconus, then in the next pictures you can see the filum terminale, which ends in the dura mater of the spinal cord. And then here is the good picture which explains the location of the, which shows the location of the Conus medullaris, Corda Aquina and the filum terminale. So filum terminale syndrome. Why filum terminale? It becomes thickened, fibrotic and shrunken. It is due to thickening of the pia mater at the lower part of the spinal cord. This film terminal, it is adherent means near the sacral vertebra. What it causes is, it will pull the spinal cord downwards. So there is a undue traction on lower part of spinal cord. Because of this, the patient will have clinical features: sphincter dysfunction, gait disorders, and bilateral foot deformities. So what is a sphincter dysfunction? I have discussed earlier. You can see the sphincter muscles, for example, in your anal opening and in your gallbladder. If it is dysfunctioned, then there will be urinary and fecal incontinence. Gait disorders. Gait means manner of walking. So there will be disturbances, or there will be changes in the manner of walking in this patient. Then bilateral foot deformities. Deformities means change in the shape of the foot. A malformation is different, deformations are different. Then Conus Medullaris syndrome. It is due to intramedullary tumor or metastasis or hemorrhagic infarct. Metastasis means if there is a tumor in any part of the body, if it spread, for example, if the tumor is in your lungs, if it spread to the spinal cord, and it may cause Conus Medullaris syndrome. Hemorrhagic infarct. If the blood supply to the Conus Medullaris is cut, then the patient will have a Conus Medullaris syndrome. The Conus Medullaris is in the lumbar and sacral region. So it will disturb the sacral parasympathetic outflow, which will cause paralytic bladder, fecal incontinence, and male impotence. Basically, this is flaccidity of sphincters. It is same as sphincter dysfunction. Flaccidity means complete relaxation of sphincters. So paralytic bladder, the bladder will no longer work, so it cannot store the urine. Fecal incontinence, the same as I have discussed earlier. Male impotence means there will be disturbances in the problems with the ejaculations, erections. Then we move on to before I have to discuss this. In Conus Medullaris, there is no lower limb abnormalities. Lower limb is not involved in Conus Medullaris, and the lesion is bilateral. And there is also bilateral saddle anesthesia, that is anus and genital area sensations are lost. In epiconus, the lesion is bilateral, but in epiconus it involves lower limbs. There are lower limb abnormalities. In Conus Medullaris, there is flaccidity of sphincters. In epiconus, there is spasticity of sphincters. Then Corda Aquino syndrome. Please note that Conus Medullaris and epiconus have bilateral lesions, but Corda Aquina there is only unilateral lesion. Since the lesion is at the nerve roots, there will be intense root pain. Because of the intense root pain, there will be irritating problems of both the sensory and motor roots. So there will be spasticity of the irritative muscles, hyperesthesia, hyperalgesia, which will lead to flaccidity, complete relaxation of the muscles. Then we will see another unique case, subacute combined degeneration. That is, the white matter of the spinal cords are completely degenerated. The lesion is at the white matter of the spinal cord. So this degeneration of white matter in spinal cord is maybe due to chronic deficiency of vitamin B12. The function of vitamin B12 is maintenance of myelin sheath, that is the protective covering of nerve fibers. With vitamin B12 and folic acid, the function is hematopoiesis, proliferation of skin cells, proliferation of gastrointestinal lining. So the degeneration may also be caused due to the chronic deficiency of vitamin B12. Here the sensory nerve fibers are spared, that is they are not get affected, and also the lower motor nerve fibers, they are also not affected. In subacute combined degenerations, the white matter, here you have dorsal column sensations are lost, and ascending tract and descending tract are also involved. So subacute combined degeneration involves both ascending and descending tracts. That's why it is called combined degeneration. Please note that at the level of the lesion, that is the lesion is in the spinal cord segment. So here there won't be any lower motor neuron type of problems. Here there is no lower motor neuron type of problems, and below the lesion, that is below this spinal cord segment, there will be upper motor neuron type of problems because corticospinal pathway is still affected here. So below the level of this lesion there will be upper motor neuron type of problems, but at the level of lesion there won't be any lower motor neuron type of problems. Then we move on to the next case. In the next case, there is degeneration of the upper motor neuron, that is corticospinal tract. There is degeneration of spinocerebular pathway, and also there are cells present in the cerebellum known as Purkinje cells. There is degeneration of Purkinje cells also. So this will cause severe ataxia because it involves spinocerebular pathway, cerebellum, cerebellar Purkinje cells, and upper motor neuron. This will cause severe ataxia. Severe ataxia means severe disturbances in the coordination of movements. So a milder ataxia is dystaxia, which is we have seen earlier in all the cases, but in this case there is severe ataxia. If this severe ataxia, if it is inherited, that is it is from hereditary, then it is known as Friedreich's ataxia. Friedreich's ataxia is autosomal recessive. Autosomal recessive means the defective gene, it is from both the mother and father. Autosomal dominant means the defective gene is either from the mother or the father. The next case or the condition is known as Syringomyelia. In Syringomyelia, there are normal dilatations or cavitated lesions of the spinal canal. So dilatations means if this is a spinal canal, there is dilatations of the spinal canal, and cavitated lesions means inside the spinal canal there may be cavitatory lesions. So this Syringomyelia condition, it occurs commonly in the cervical region, so it involves dominantly the upper limbs. So these dilatations may go anterior, lateral or anterolateral. So let us discuss what happens with the direction of the dilatations of the spinal canal. So if the spinal canal or if the dilatations happens anteriorly, you know the spinothalamic tract which enters the spinal cord and it crosses and moves upwards, they are affected. So the function of spinothalamic tract is pain and temperature. So these fibers are affected. So there will be bilateral loss of pain and temperature because both the nerve fibers tracts are affected at the center. So there will be loss of pain and temperature, but only this spinal tract is affected. Only these two spinal tracts are affected, the rest of them remain normal. So the patient will have normal or intact fine touch, position and vibration. If the dilatations, if it moves on the anterior lateral side, then there will be wasting of upper limb, since Syringomyelia involves commonly around cervical region and it dominates the upper limbs. So why there is wasting of upper limbs, especially lumbricals and interosseous muscles of upper limb? It is because the dilatations, they move anterolateral side, so the lower motor nerve fibers are also affected. So here in this segment of the spinal cord, the patient will have lower motor neuron type of problems in the upper limb, that is flaccid paralysis. Then if the dilatations, they move on the lateral side, please note that the dilatations of the spinal cord, they go in symmetrical manner, that is like this. So you also know that if it move on the lateral side, there is corticospinal tract, and you also have nucleus of Budge, both are affected. So the patient will have bilateral Harner syndrome, and below this spinal cord segment there will be upper motor neuron type of problems, which is spasticity. So we have seen the dilatations of the spinal canal, normal dilatations only. Then we will see the cavitary lesions. So why there is a cavitary lesion? You have your cerebellum. If there is a herniation in the cerebellum from the foramen magnum, what happens is the CSF cannot escape and it forms a cavitary lesion in the spinal canal. You can see this in this picture. So this causes cavitary lesion, and this condition is known as Arnold Chiari malformation. So the dilatations or cavitary lesions we have seen here, they move downwards, but if these dilatations or cavitary lesions, if they move upwards, that is like this, that condition is known as Syringomyelia, and that condition will involve lower cranial nerves. So in all the cases we have discussed in this lecture and in the part 1 lecture, in the trauma, cervical spondylosis, Syringomyelia, in all these cases the common region involved is cervical vertebra. The only difference is that in trauma and cervical spondylosis the patient will experience pain, but in Syringomyelia, that is in the normal dilatations or cavitary lesions in the spinal canal, there is no pain, and in Syringomyelia, at the level of the lesion there is lower motor neuron type of problems concerned with the upper limbs. Below the level of the lesion, that is below the spinal cord segment where the lesion is located, there will be upper motor neuron type of problems because of the stoppage of corticospinal tract information from the affected spinal cord in the lower limbs. So the upper limbs will have lower motor neuron type of problems such as flaccid paralysis, hyporeflexia, and the lower limb will have upper motor neuron type of problems such as spastic paralysis, hyperreflexia. Please note that in Syringomyelia it occurs around cervical region involving upper limbs. So let us move on to the next case, multiple sclerosis, a central demyelinating disease. and it is a recurrent disease. Why it is central demyelinating disease? Because it involves only the central nerves, not the peripheral nerves. So it is a central demyelinating disease. There is demyelination of the central nerves. In Guillain-Barré syndrome, there is demyelination of the peripheral nerves, and the Guillain-Barré syndrome is a non-recurring disease, but multiple sclerosis is a recurrent disease. In multiple sclerosis, white matter in the central nervous system is sclerosed. A multiple sclerosis is an immune complex mediated disease. That is, the cell mediated immunity, they destroy the oligodendrocytes. Oligodendrocytes are cells present in the your brain. So the common problems the patient experiences are optic nerve demyelination. There is demyelination to the optic nerves, and the median longitudinal fasciculus also demyelinated. So here you have the degeneration of your medial longitudinal fasciculus tract, then degeneration of the corticospinal tract, and degeneration of the dorsal column tract. This median longitudinal fasciculus, it connects the 3rd, 4th and 6th cranial nerves and also the other cranial nerves. So this median longitudinal fasciculus, if it becomes demyelinated, then the 6th and 3rd nucleus, cranial nucleus, they will lost the interconnection, leading to eye movement disorders. You can see in this picture there is an eye movement disorder between the right and the left eyes, and this multiple sclerosis, it involves both the ascending and descending tract, but it will not include sensory gray matter, motor gray matter, anterior root or posterior root, because the degeneration is seen only in the white matter. That is, the sclerosis is seen only in the white matter. In the white matter of the spinal cord, you have only the ascending tracts and descending tracts. So the gray matters are spared, not affected. Then the next case, there is a lesion in the dorsal root, and in this condition the lesion is progressive and spread to the dorsal columns, and it spread to the white matter and gray matter of the spinal cord. This condition is known as Stabis Dorsalis. You see this condition in tertiary stage of syphilis caused by Treponema pallidum. Treponema usually present in all human beings. That treponema is non-pathogenic, but the treponema which is transmitted through the sexual relationship, that is pathogenic. So the treponema present in normal human body is non-pathogenic, but the treponema that is transmitted through sexual relationship is pathogenic. Transverse myelitis. Transverse myelitis is due to the inflammation, virus infection and infarction, that is loss of blood supply. If there is no blood supply, then there will be death of tissue and cells. This is known as infarction. So that's it for the spinal cord and its diseases lecture. Thank you.